So now it's my turn again, and I'm going to present the clinical evidence and how that guided our development of the clinical criteria. Clinical evidence, why do we need it? Well, these are diagnostic clinical guidelines, so it's really important that we base this on the evidence. And as you've heard me talk about, Australia was undertaking this rigorous systematic review of the literature as part of their guideline review. So I'm going to be talking about a lot about that process next, just to really try and outline how that happened. Some of you will be academics and you'll know about systematic reviews and how they come about and grade criteria, but some won't. So I'm going to try and break it down for you. We were really lucky for this collaboration because they were very generous. At the same time, Sarah and I were also part of their review team. So I was part of their guideline development group and helped to develop their guideline. I've also been part of the process to gain NHMRC approval, which is an incredibly rigorous method to show that the evidence has been interpreted correctly, which also includes seeking international expert opinions from other people who diagnose FASD. So why is this important? Now, I just want to credit Professor Zach Munn from the University of Adelaide for this slide. But, you know, in the good old days, the good old boys, and mostly boys or men, sat around the table and made decisions about what should be included and what shouldn't be included in clinical diagnoses. And this was the way, and still is some of the way about that is used for, say, the DSM, those of us who are psychologists and psychiatrists who diagnose mental health diagnoses. This is how really it came about. And it's problematic because there is huge risk of bias and it shows a lack of consideration of all pertinent areas of the criteria. People, even if they try and be unbiased, we still see the world through our own lens. And so it's really important that we come as much as we can to try and really critically review all the evidence out there. So I'm just going to take you through what a systematic review, what the process is. So there's a fairly strict protocol about how you do this. And so the Australians looked across all these databases, PubMed, Web of Science, MBAS, PsycInfo, all of those, to look for all the evidence around the diagnostic criteria areas. They came up with 18,000 pieces of research. So the first step is that you remove all the duplicate records. So that there were 10,000 duplicate records in there. So that takes the number down to, I think it was 7,700. Then records are screened again by title and abstract, and a number of records are removed again when the language wasn't English, it was off topic, it was a preclinical study, there were few participants in there. So really trying to find the best research that we can gather and understand and not bias research into areas that were really off topic. Then the full text articles are assessed for their eligibility. So, and that was, you know, exclusions included, there was no relevant data, there was no control group, it might have been the same cohort, the same group of people as another study. So once those were taken out, the studies included in the systematic review were 225. There were a couple taken out further because it was a critical risk of bias. And then there was about 64 added in because they updated it with more recent literature. So the total in the end was 287 pieces of research. There were 100 articles or records around physical size, 45 for dysmorphology, facial features, 179 for functional neurodevelopment, and I'll talk you through those, but those are the brain domains that we assess, and 105 for structural neurodevelopment. So that might be head circumference, MRI, research, seizures, more structural brain, things that we might look for. So this is just an example of an area, one of the diagnostic criteria, which is physical size. And you'll see that it's split between exposure studies, which were 67, and diagnosed studies, which were 35. That's because in the literature, some studies talk about prenatal alcohol exposure and some studies talk have people included that have a diagnosis of FASD. So it's really important not to confound that, and so they looked at those groups separately. So you'll see there that all the studies were birth weight, birth length, low birth weight, percentage, small for gestational age, postnatal weight, postnatal height, at using different measures for both those groups. To give you another example, this is the functional neurodevelopmental and structural and neurological. Again, exposure studies and diagnosed studies separated out. And you'll see for the functional neurodevelopment, there were some domains that had quite a few studies, behaviour, for example, where others such as memory didn't quite have as many. And you'll see that there's almost half the amount of studies in the structural groups where birth, head circumference, and MRIs and seizures, they're very few. Okay. So, evidence to decision domains. Okay, so this really, so every criteria and research, what we're looking for is the certainty of the evidence. How sure are we that prenatal alcohol exposure at a particular level is going to cause an impairment to the level that someone would have an FASD diagnosis? Starts off with initial certainty of evidence and then includes a lot of review factors. So we're looking at the magnitude of the effect, how big the effect is. Is there a dose response? So higher levels of alcohol versus lower levels. What's the other confounding factors? What might else be going on? What in the research is the risk of bias? What's signs of inconsistency or imprecision? Or publication bias. And all of these give a final certainty of evidence, which is rated as a high certainty of evidence, moderate, low, or very low. And again, this is just an example. There are so many of these plots for every single data point. But you'll see here, this is a small for gestational age. And the pink line here, which is further out, is very heavy prenatal alcohol exposure. So what this shows us is that there is a strong certainty of evidence that very heavy prenatal alcohol exposure has an effect and causes small for gestational age and less certainty at the other levels. So an evidence to decision framework provides a concise summary of the best available research evidence to inform judgments about each of the framework criterion. It ensures that important factors that determine a recommendation are considered, and it makes the process of developing recommendations really transparent to guideline users, because all of this information is then available alongside the guideline. So at the moment, the Australians have had that NHMRC, they've had that reviewed, and they're in the process of addressing all the questions from NHMRC, and then they'll be resubmitting that. And there were a lot of points that needed to be worked out, but most of them were just about, we need this explained a bit more, we need that. It wasn't that the evidence, there was problems with the judgments that had been made. So just to give you an example, these are the types of judgments and these are the areas. So what people are looking at is, what is the strength of the association? Is it small? Is it moderate? Is it large? What is the certainty of the evidence? Is it low, moderate, or really high? Does it fit with the values of what we're trying to do? Is it going to take a lot of resources or costs, or might it save some money if we put something into the criteria? And what is the certainty of the evidence of the required resources? Is it going to help equity? Is this guideline going to be acceptable? Is it feasible? And what is the diagnostic utility? So all of these things are considered in a really methodical way by many people in the group, based on all the evidence. So now, and I don't expect you to be able to read this, but all of this meant that we came up with this diagnostic criteria. So you might remember at the beginning, I talked about a clinical wānanga. So we all met here in Hastings back in October last year. There's a group of clinical specialists, and Dr. Natasha Reid came over and presented a lot of the research, and we reviewed the criteria. We reviewed how that was going to work for us in Aotearoa, and yeah, it came out of that day, I think, pretty consistent. And then from there was just constant revisions. So I'm not going to go through all the detail. You can read that in the in whakakotahitanga. But this is set out in a similar way to how they are set out, the diagnoses are set out in the DSM. And we did it this way mostly because clinicians are used to reading it like that. So criterion A looks at the evidence of prenatal alcohol exposure. Criterion B looks at the presence of pervasive neurodevelopmental impairments. Section C says that these difficulties cause significant impairments which require a lot of support. Section D, the onset of neurodevelopmental impairments is evident during development. Now, we know that not everything is evident, but usually, even if you're assessing someone and they're an adolescent or a young adult or even an adult, you can usually see earlier on that things weren't going well, even if it wasn't picked up. So we want to see that this is pervasive and it's been present. It might be building, but it's been present for a long time. And both the next one, criterion E, is that those symptoms are not better attributed to another conditional exposure. And in the guideline, there's a lot more detail about how to make these decisions. So the diagnosis is FASD, and there are specifiers. So it's either with or without facial features, head circumference, or physical size restrictions. So we've had some questions about whakakotahitanga, and we can't tonight answer all of them, but what we wanted to do is really pick up on some of the common questions that we'd received. So there's been questions around prenatal alcohol exposure levels. So the criteria is for high and very high exposure, and depending on the evidence, you can also assign moderate exposure as being evidence for prenatal alcohol. So the reason we say clinical judgment around moderate is that sometimes the way we get the information isn't totally the same as what we need it for to have high or very high. So on an average, it might be quite a low number over the number of weeks, but the pattern means that it's a binge drinking pattern. And when we look at all the factors, we think that there's a high risk that prenatal alcohol exposure has caused these neurological impairments. And it is about clinical judgment. Everything we do and the way we gather information is not exact, and it is not a tick box exercise. There have been questions why we don't include light drinking. And first of all, I have to say that there is a difference between what we need for public health messaging and what we need for diagnostic criteria. For diagnosis, we need the evidence to show that there's a clear association between that level of prenatal alcohol exposure and the level of impairment that we would want to see to give a FASD diagnosis. And there is just not the certainty of evidence that light drinking is associated with the level of impairment that we would see for someone that met criteria for FASD. And also, it's interesting, if you really look in the detail of the research, there's differences in how researchers classify prenatal alcohol exposure. For example, one piece of research I was looking at talked about a group being the light reduced group. So you'd think that was light drinking. Well, when we translate what they were actually talking about, light reduced, that would meet criteria for moderate exposure. So we have to be careful about the words we use. So yes, prenatal alcohol exposure at lower levels may affect development, but there is just not enough evidence that it affects development to the extent of the impairments that we would see in FASD. The other area we've had questions about is diagnostic thresholds and the move away from 2 standard deviations below the mean. This guideline has a lot of information in Appendix A, which details the problem of using specific percentiles and the need to consider normative samples. There are very few tests that are normed in Aotearoa New Zealand, and we have to be really careful the way we use them. And so specific points need to be clarified by using confidence intervals or a range. We, again, do not want to be a tick box exercise, and clinical judgment has to be used to ensure that test performance and what we hear through interview or see through observation, those indirect measures, both represent severe neurodevelopmental impairment, and where the best explanation for that is prenatal alcohol exposure. We should always be using ranges and confidence intervals for reliability and validity. There is very good evidence that people do not show the same performance from day to day, and we should always consider the contextual factors and confidence in the data that we're getting and be thinking about this broadly. Diagnostic terms, there were some questions about what the diagnosis is. The diagnosis is FASD, with or without those specifiers. And finally, there were questions about other functional areas like sensory not being included. Unfortunately, when they haven't been included, it's just that we don't have the research evidence to say that that level of prenatal alcohol exposure causes sensory challenges. That's not to say we shouldn't assess for it and we shouldn't look and we shouldn't use that information in terms of management strategies, but for a diagnostic criteria, it needs to be based on the evidence. So I think that's about me for this evening. I will be here just helping to answer some questions, and if we can't answer, then we will get back to you. But just once again, thank you so much for tuning in, and yeah, see you soon.